So, I was asked to talk about what my Stew project I've been doing for about a year and a half, 2 years now, but with more of a reflective slant and what I've learned from it, what I can impart to you of knowledge. I'm one of the geriatricians, although we're now called SAMS, Senior Adult Medical Services, it don't have to be called geriatrics, so we're changing things around a bit, and I'm at St Peter's. So I found that when I became a consultant, I asked myself that what I can do as a doctor is not actually what I should be doing most of the time. And I really quite start noticing when I became a consultant. So I started a project initially with the Living Well to the Very End project, part of the Point of Care Foundation. And they taught me a lot of QI methodology. And I was very lucky at St Peter's in that I had a very good QI department who gave me kind of the grounding on how you can measure and look at what you're doing. Then at that event, actually Leslie was there talking about her husband's death, and one of the things that hit me very strongly there was little things do matter. It is always the little things. I've got multiple examples, but even just in this room we heard this morning Jill mentioning about the little thing she was given by the patient's relative just for noticing a cup of tea. On my table earlier on we were talking about that you stop noticing all the clutter down the walls or the corridors, you walk in that environment so much you don't notice it. So there's so many little things that do matter. But what we're all quite aware of is that within the NHS we are stretched. We came into this job mostly not for the money, but for other reasons, and those reasons, those joy work, those reasons we started in the first place, are often dissipating out a little bit. So we have to connect back with what it was that we're doing these jobs for. A bit of that emotional reasons why we're doing our jobs, and only by connecting to that can we get the staff to engage in the projects we're trying to do. I put the elevator pitch down there because it was one of the things I was asked to do at this project. And I remember everyone talking about all their great ideas they were going to do. There was butterfly schemes, there was all kinds of schemes. And I was like, I don't know yet. And so basically my elevator pitch was to do shadowing, to work out what it was that I wanted to do. And it was actually one of the best things that I did, and not to jump into what I thought we should be doing, but listening, we've heard that before, listening to what I should be doing and then doing it. So we came up with the aim that all patients and families say about staff, we listen, we care, and you know me. We understand each other, and I trust you. Trust is very important, and I feel at ease. We wanted all the staff to say that I can listen, care, and know you, but we act together for your needs, and that our trust support our staff to do this, and that's quite key, because without the time to support, we're not going to manage it. So part of this Point of Care Foundation was looking at shadowing. I've never done it before. I was a little bit sceptical, if I'm going to be honest. The idea that I could sit there with a patient or relative or a situation and learn anything more than my however many years in the NHS has taught me, I was a little bit dubious. But it did, because suddenly you're sitting there, I'm not acting as a consultant, I'm not acting as anything, I'm just sitting there and observing. And all those little things that you've noticed or would notice as a relative come popping up into your head. And we also included staff all across the hospital, from admin staff to volunteers to schools, children, sixth forms, but all different types of ages to come and shadow the same experiences. And funnily enough, the same things came out, and it is the little things that matter. I was asked to write an ideal experience at the end of this, and actually, I couldn't, because my ideal experience is not yours. So writing an ideal experience, I have to ask that person what their ideal experience is to be able to get the answer to that question. So some of the things we found: clutter. It's amazing how much clutter there is in the hospital. One of the main things, I was working on a male ward at the time, and the urine bottles are on the table that you have your lunch. Everyone would go shock horror at that. But in the hospital, that is an everyday walking into a real situation. It's an easy access place, it's there. If someone is approaching the end of life and they're bedbound and not very engaging at that time, amazingly how much clutter, the spare mattress bags or the spare nebulizer machines, they all come into around that bed space. Lack of confidentiality. I always use this one, is that if I want to know if a person's bowels are open in bed 1, I just ask bed 6. Because the curtains gives you no privacy whatsoever. There is no stimulation, there's no interaction. You lie there looking at the same peeling ceiling, those tiles in the hospitals that have been there, day in, day out. And for a lot of my patients who are in for a significant period of time, that is deconditioning in its extreme. Information, we've talked a lot about giving patients and carers some information. There's very little of it, or if it is, it's stashed in a drawer that no one gets access to. Communication of that, everyone's too busy to communicate, so you can't get any of that. And you end up finding people who had the kind of stale food by the patient who's dying, who couldn't eat, while as the carer that really is quite hungry and sat there all night, doesn't get anything. So there was a bit of amendment doing. So I asked my team, what does good care look at? And the first thing they come to me, we know it gets wrong. We get our day texts, we get our complaints, we get our pals. And I said, so what's the problem? Why don't we do what we would expect to care for our mother or our father or our loved ones? And you got very different answers. So we had time. Time is number one. Everyone said, I don't have time. And even me, if I'm there on a ward round, I can sit with that person, explain a little bit more, but my clinic's overrunning already. I've got to get to clinic. Who do I disappoint? The person there or the person in clinic? Both of those times are important. But then there was also things like, well, that's not my job. And not in a not jobs worth side of thing, which I don't get that bit, but there was the people going, well, I might get told off, you might tell me that I'm overstepping my boundaries. So there's a bit of giving permission. So I said, okay, how are we going to fix it? How are we going to solve this? We have a lot. We've talked about friends and family, we've talked about, so if you go to the execs, they want the length of stay, they want discharges, they want flow. We're using red to green in our hospital as well, measuring what a non-productive day is. But pretty much the staff just say, don't you give me any more paperwork. No more paperwork. So that takes away from the time to communicate and have these conversations. So where do we start? So we came to the idea of if you don't know if you don't ask. So we sound, for example, a touch. A touch can be comforting. But also, a lot of people, that's really quite intrusive. I don't want to be touched by a stranger. How do I know what you like until I ask you? So we adopted the idea of what matters to you, which for those that know, started off with Anders, I think it's Anders Berger, is the way you describe him, to pronounce his name, and he was a Norwegian nurse, and he went to care homes where he saw patients' names and what room they were in, and what their diagnoses were. And instead of that, this care home had written, I want a glass of whiskey at 8 o'clock, please. Or don't dare let me come out my bedroom without my makeup on. You know, those kind of personal things. So we wanted to adapt that idea to make it work in a hospital setting. And we wanted to include staff, because as I say, without the staff, a geriatrician, I'm all about my MDT. I could not do the job I do without many, many other allied health professions. I have seen sisters cry at the loss of one of their patients. And she has to get up and do it again the next day. So how do we support each other to do this day in, day out? So measurements, I had to get measurements. My board and my execs are not going to let me do anything without some kind of measurements and outcomes, so we had to do that. But really, people on the ground, they didn't care about measurements. I wanted to improve handover, so that when a nurse left that shift, what they had learned during that shift could be handed over to the next shift, or what we've learned during that hospital stay could be handed over to the community. If you can imagine a nurse at 9 o'clock or a healthcare assistant, a relative comes in, if they could give that information rather than me as a consultant in my working hours, that's just saved us all better information. So we did a driver diagram, many, many different projects. These will all come out of the staff, so this was co-designed by staff. They came up with the ideas, they came up with what was important based on their shadowing experiences. We try to include staff, make them feel proud of what they're doing. Someone talked about corridors. So our corridor is very colourful, as you can see. We talked about what we're doing. We talked about what's important to different people. We included everyone. One little reflective bit is that I did try to start off with having champions. It didn't actually work. Everyone talks about having champions and using someone to champion something. I don't know whether it was to do with, I tried to use that as HCA level, so ground level people. They do the most of the care, the most communications with staff, with patients. And when they didn't feel strong enough, they didn't feel empowered enough yet, I don't know, but that didn't work for me. So it was more about just giving everyone pride and a bit of momentum into doing it. So those hands now are laminated, because I can't get the money to get them on the proper board, headboard, so we just laminate these and they go above the beds. And then every day, or even multiple times a day, if a carer wants to write something, if a relative wants to write something, if an HCA notices something like my left leg's really tender, they write it on here. That means that the next carer comes, they can see exactly what it is that's bothering that patient. If the person can't speak for themselves, we encourage relatives to do the same thing. We have postcards for staff as well. So we ask the staff what's important to you, what's getting up, what's not working at the moment. And those go on postcards that we also put up. These are some examples. So it's not rocket science, it's just literally asking the person what's important to them at the time. To have your table in reach so you can have that drink of water. To get married, I was quite excited about that one. They ended up with a restraining order, so less good. But they're very simple things. I learnt to blog, I learnt to tweet, I learnt all kinds of computer things. My husband would be astounded I've managed to grasp. But just to try and get some recognition for the team, for what we were doing. And that brought more people on, they felt more pride in what they were doing. We developed a communication skills, which is aimed at, we've got many different nationalities providing basic level HCA care, so some standards in how they can approach communication. It's all on the slides. And then measurements I talked about. Those were for me to go to everyone else and say, this is what we've done. We managed to reduce family delays. So by not communicating to the family that this person's going to go home in a couple of days and their room needs to be cleared so they can have a hospital bed put in it, usually it doesn't happen to the day we're expecting to discharge them, at which point we've already got a delay. So we've managed to reduce that by communicating with relatives a bit better. Same thing with care homes. If we don't give care homes notice they're going to be coming out soon, they can't come and assess the patient, at which point they can't go home. So those were simple wins. We talked about advanced care planning, talking to a person what's going to happen. If we recognise in those last 1,000 days are there, how are you wanting to look? In a kind of non-frightening stage, you're not there yet, but let's just start having this conversation. And then how does that get communicated to the GP? How far have we got? What else can they talk about? And then, like I said, a lot of it was about MDT, collaboration, patient safety. So we did improve from a 40% improvement in that. Just by the team feeling more empowered, they can come to talk to other allied health professionals, try and get the job done between each other, rather than one person feeling the burden of certain responsibilities. So those are our aims. They still are our aims, and I can't say we're completely embedded, but it is just an everyday thing, and that's the idea we're trying to develop with ethos. That's it.